you very much. I came to this topic when I was asked to give a debate with Jackie O'Leary at ILTS in Chicago a few years ago. And I came to that as a skeptic, and I have to say that I'm largely a skeptic, slightly more educated. I do believe antibody-mediated rejection occurs. It is an entity. It is difficult to diagnose, particularly early. It's incredibly easy to overdiagnose. And I think one of the messages I really want to get across when we consider this is, yes, you look for it, but please don't overdiagnose. Because the implications for your patients, if you overdiagnose and administer the treatments that are putatively helpful, then I think you're doing your patients a disservice. Taking a historical perspective, we, for many years, certainly those of us who were in liver transplantation for a long time, felt that humoral rejection was not relevant to the liver. And the kind of evidence that we looked for was that hyperacute rejection is phenomenally rare. And an early observation was that in patients who were highly sensitized, actually had very successful outcomes after transplantation. So much so that liver transplantation actually was proposed as a treatment option for highly sensitized patients having kidney transplant. And early retrospective studies really didn't find any association between DSAs and poor outcomes. So we were quite complacent for a long period of time that the liver was immune to this difficult process of antibody-mediated rejection. Now, about 5-6 years ago, a rethink, and I think this is largely due to Jackie O'Leary's work in Dallas, where she started off by trawling a pool of patients, 60 patients, late graft failures. And in that highly concentrated group, she went looking for evidence of antibody-mediated rejection as a cause of that graft failure. Now, a little over half of those patients had had DSA, and when she trawled down deeper, felt that this was not relevant in the majority, but she felt that 3 patients had classical antibody-mediated rejection, and 3 patients had incomplete antibody-mediated rejection. So this started a series of work and discussions about the role of antibody-mediated rejection in the mediation of late graft loss. Now, I think, as I said in my introductory comments, I accept that antibody-mediated rejection occurs. I think it does cause graft failure, but it is still relatively unusual. The trawl, or the screen for looking for potential candidates with antibody-mediated rejection is donor-specific antibodies. But a very important point is that these need to be class 2, they need to be present in high titer. Ideally, they need to be directed at a DRQ, and they need to persist in the context of the pathology. So if they don't tick those boxes, if they're class 1, if they're intermittent, if they're fairly low titer, they should be eliminated as evidence of antibody-mediated. The classical definition then proposes compatible histology, and I'll go into that, and that is still, I think, a work in progress. And the final element of the approach to trying to identify these patients is the use of C4D staining. Again, it has its problems, but it has its utility. The first bit of evidence I want to share with you is preformed DSAs and the outcomes over the first year following transplantation. This is a study which is prospective. It is 90 consecutive patients, and it included 20 patients who had preformed donor-specific antibodies. 12 of these were class 1, 5 were class 2, and the remaining 3 were both class 1 and 2. The reproducible phenomenon is that after transplantation, the titers of these antibodies falls very quickly, and is 90% reduction by the end of the first week. And in this study, they were unable to identify any pathological outcome that correlated with the pre-existing donor-specific antibody. And this is in keeping with our historical perspective. Another study that takes a different approach, and it is looking for antibody-mediated rejection, not prospectively, but retrospectively. Again, a larger study, 182 patients involving 197 transplants. That included 10% of patients who had positive cross-match or DSAs, and 15 of these reversed their antibody status within a couple of weeks of transplantation, consistent with the previous study. But this study did identify antibody-mediated rejection in 3 patients, that is about 1.5%. And I still think that is probably the right feel for the frequency with which this phenomenon occurs. The histological diagnosis of antibody-mediated rejection is difficult. The Banff criteria were published in AJT fairly recently, but I think there are a couple of introductory points that are worth making. Firstly, it took 3 meetings to come to a consensus that was published. The second point is that it is considered to be work in progress and taking a fairly conservative approach to the diagnosis of antibody-mediated rejection. And the third introductory comment that I would make is that while Jake Demetrius and Chris Bellamy wax very lyrically and very persuasively about these histological findings, that is not transferring into the working histopathologist. So our own histopathology service at King's finds it difficult to apply these criteria as described. So the criteria for acute antibody-mediated rejection, that is in the first week or so post-transplant, include microvascular injury, the concept of endothelial hypertrophy, which I think is hard to estimate, an inflammatory process, ductular reaction, and occasionally arteritis. Now, the difficulty with making a diagnosis of acute antibody-mediated rejection is that the vast majority of these cases also have classical T-cell mediated rejection. So differentiating the two processes is, in fact, quite difficult. And the management of it is actually essentially the management of the acute cellular rejection. Whether or not antibody-mediated rejection is overrepresented in the 2% or less of patients who lose their grafts to this process is an unanswered question. The features of chronic antibody-mediated rejection are a chronic low-grade inflammatory infiltrate, which will include plasma cells and lymphocytes, interface hepatitis, but I think most importantly, as a differentiating feature, are the sinusoidal changes. And in addition to these, you can get a fibrosis and architectural distortion. So what I'm going to show you is a 3-month biopsy in a case of ours that I think does represent antibody-mediated rejection. And this slide points to the sinusoidal dilatation and the congestion with blood extravasation. And I think, in my view, that that is probably the alerting finding. That is probably the earliest finding that we should be considering in patients who might have antibody-mediated rejection. In this patient, the graft failed, and she was retransplanted at 10 months. And the first of these slides looks at the sinusoidal dilatation has become more dramatic. There's now much more blood extravasation. You can see there is also a cellular infiltrate consistent with standard cellular rejection. And there is, when you look at the veins, both the portal veins and the hepatic veins show significant disease. And I think this would be accepted as a case of true antibody-mediated rejection. This is a slide illustrating the C4D staining pattern. C4D staining is non-specific. It has problems in terms of how it's handled in the laboratory, but it is a pointer to where disease may be occurring, and if it's linked to compatible histology, it is considered to be one of the features, diagnostic features of the condition. Having said that, this is a panel of slides 7 days post-transplant. It actually is from the prospective study that I described earlier on. It, through the whole series, demonstrates the presence of positive C4D staining. And again, in this patient, with all of the classical signs, there in fact was no evidence from a clinical perspective or from an outcome perspective of an antibody-mediated rejection damaging that graft. A couple of meetings have been held in Dallas to try and brainstorm the whole concept of antibody-mediated rejection and DSAs. And don't try and read this slide. I'm going to highlight what I want you to see from the beginning is that the conclusions of the second last of these meetings really only identified 3 facts, and you see they're actually very general. But it does throw up some possibilities and some opportunities that we should be engaging in taking this forward. So the facts as they determined were that they agreed that antibody-mediated rejection occurs, and I would concur with that. The next 2 are actually relatively banal. The second is that the liver does not completely protect the kidney, and the third is the sensitivity and specificity of DSA staining is variable. Now, that's not just the interpretation, but the actual laboratory abilities. However, some of the possibilities are interesting. And there's a suggestion that DSAs may lead to pathological outcomes in classical AMR, but they may also act as cofactors or synergizers for other pathologies. And in this context, hepatitis C was particularly implicated. They may accelerate fibrosis, and it is of note that the latest Banff criteria on humoral or antibody-mediated rejection accepts idiopathic fibrosis as a manifestation of that process. And obviously there may be an interaction between the humoral and the cellular elements in all of the classical forms of rejection. Looking at DSAs, I think, is something that we should be doing more systematically in our practice than we currently do. It may help us define pathology, but it may also have other implications in how we manage our patients. And one of the interesting questions is, why are we talking about AMR in 2016, 2017, when 20, 30 years ago it wasn't recognized as an issue? There are at least two potential explanations for that. One is that we're just better at recognizing it, we know how to look for it, and it's an issue of diagnostics. The second, and more intriguing one, is that it's an unintended consequences of our changes in immunosuppression. That maybe we are subjecting a small percentage of patients to this condition because of our process of optimization, which usually is linked to minimization. And the data in terms of immunosuppression and the outcome of antibody-mediated rejection is actually very weak. But for what it is, it does indicate that higher levels of tacrolimus, maintenance immunosuppression, is associated with the least risk of developing this complication. How do we treat it? That slide has come out all over the place, but in fact it beautifully represents where we are in how we treat antibody-mediated rejection. We're all over the place. We try removing the cells by plasmapheresis, we try depleting them with various antibodies. But the truth is, in my experience, that if you get to the stage of having fairly obvious barn door antibody-mediated rejection, nothing works. Simone Strasser from Sydney claims that she has salvaged 2 patients very effectively with a combination of plasmapheresis and rituximab, but we've never been able to replicate it in our practice. So to conclude, tacrolimus-based immunosuppression remains the best immunosuppression strategy post-transplant. I think that's a statement, it's not developed from this talk, but I do think we need to wonder whether patients, at least those at risk, by defining pre-existing DSAs or appearance of DSAs, should be managed differentially in terms of their exposure to tacrolimus immunosuppression. And the current trend towards individual minimization may either be an innocent bystander in this process or may be contributing to its conspicuity where we are. The diagnosis of antibody-mediated rejection needs to be limited to classical cases. It has to be type 2 DSAs in high titer and preferentially DRQ. You have to have the compatible histology, but I think that is still a weak link in this diagnostic process, supported by appropriate interpretation of SEED4D staining. And going forward, the one thing I would recommend is that we think about this more, look for it more, and try and prospectively evaluate the real consequences of this phenomenon post-liver transplant. Thank you very much.